Good morning. Roll call. All right, Representative Chadwick.
All right, good morning, committee. Welcome. Now that we are live and streaming, welcome to Labor Health at 7:30. And Marilyn, if you'd call the roll.
Representative Chadwick. Representative Klauston. Representative Hornick. Representative O'Hearn.
Excused.
Representative Penn.
Here.
Representative Trujillo.
Here.
Representative Ward.
Here.
Representative Yen. Chairman Zwanitzer.
Here. Well, committee, we have 3 bills before us this morning from 7:30 till 10. We are currently still trying to locate the sponsor of the first bill on our agenda, which would be 122. But until we find him, we will shuffle the bill order and start with House Bill 206, State Employee Child Care, brought to us by Representative Yen. Representative Yen, floor is yours.
Mr. Chairman, thank you. Members of the committee, I bring before you House Bill 206, State Employee Child Care. I'll speak to the intent of the bill and then we'll run through it pretty briefly. The intent essentially is to provide an incentive for both hiring and retention for state employees. I think many of you know that there are quite a few vacancies. Some of it, can be due to compensation or benefits, and this provides something that is fairly affordable that could be a consistent benefit to state employees in the Cheyenne area. Unfortunately, it isn't a bill that provides childcare to all state employees across the state. It is one that focuses on Cheyenne specifically, but I thought that that is a good place for us to start a conversation. I do have an amendment that I have forwarded to all of you guys' email as well as staff's email that provides an option for the committee to consider of charging for childcare. So the benefit would still be having a consistent and reliable place for a child of a state employee, but with the alternative amendment, it would still require them to charge a market rate for that. And so that's just something for the committee to consider as a policy decision on whether it makes sense to charge for it or provide it as a benefit to Cheyenne employees. So I'll run through the bill. Page 1 basically creates the section and statute that creates the definitions as well as what the actual action would be. So we're talking about the Capitol complex, which is the area that the Capitol sits on, as well as the Hirschler and the surrounding area that is defined in that statute. Certified child care facility is one that is certified by DFS. There are a couple of other child care bills, and so I'm sure you will hear about what that means. There's just licensing involved to make sure that it is a licensed certified child care facility. State employees just means employees of all 3 branches of the state government, executive, judiciary, and legislature. And then we talk about what it actually does. Is the idea would be to establish a facility in the complex. It doesn't really define where that facility should be. What would happen in page 2 essentially is page 1 and 2 is that a plan would be created to come to us next session on what that could look like. There are a couple different places that I imagine where we could put it, but I didn't want to specify that in the bill. I wanted the General Service Division and A&I to determine what makes the most sense in the Capitol complex. And so it's, again, pretty simple. Page 2, they also have rules to govern it. And on page 3, lines 9 through 14, it defines, because there's a possibility that there could be enough children where it could be filled. We want to make sure that that there is who is actually eligible, as well as if for some reason it's full on 16 through 18, they can create rules to define what do you do if there are more people eligible than can fit in the facility. And on page 3, lines 13 to 14, that's where the amendment really takes effect, is determining whether it's at no cost versus cost to the employee. And then on page 4, we put it into the General Service Division, just also reference this new clause, this new article that talks about the childcare facility. So it ensures that the General Services Division knows that that's their responsibility as well. And then you have section 3, which talks about bringing it to the next, bringing up information as a budget request for the next budget to determine how you'd set up the facility. And so I will stand for any questions. Thank you, committee.
Questions for Representative Yin? Just knew one of you. Representative Penn.
Thank you, Chairman. Representative, do you have an estimation on what the guesstimate on number of kids, and also what ages are we talking?
So unfortunately, I don't
ahead,
think we,
Representative Yin.
oh, sorry. Thank you, Mr. Chairman. I appreciate the reminder. Unfortunately, we don't have data on the number of kids that state employees have as a total, because we don't keep track of that anywhere in our human resources, right? So I don't know. I unfortunately do not know. But I would hope that regarding this plan, ANI would be able to give some sort of estimate based on general, either from other states that have the same type of benefit for their state employees, or from other companies and that generally have this as a benefit, where they could measure on average how many kids per employee that a company has in an area. So unfortunately, I don't have that number now.
Okay, Representative Hornick.
Thank you, Mr. Chairman. Question on the cost estimate, and that's I think, the gap that I have in this is, it also includes building improvements. So first, do we have an idea of where that might be housed, how much those building improvements might be? And then we're talking, at least in the way the bill is now, the funding for the staff, the services, all of that stuff. Do we have any idea of what that might be?
Go ahead, Representative.
Thank you, Mr. Chairman. Representative Hornock, the building improvements, I think that there are quite a few rooms that are very rarely used in the Capitol complex. And so I think when regards to improvements, probably not that many. The biggest probable cost would probably just be labor over the course of a biennium to make sure that it's staffed. I don't think that there would be a lot of actual capital improvements involved. But I don't have a number on how much it costs to run a daycare. And that's why, and that's part of the reason why I didn't put it in the bill itself, because if for some reason we don't like the costs, we just don't fund it come next year.
Okay, other questions? Representative Ward, and then we'll go to, go ahead, Representative Ward. We'll start with you.
Thank you, Mr. Chairman. My question is, can you help me respond to the argument that this bill looks like we're voting benefits for ourselves?
Representative Yin.
Sure, Representative Ward, if the committee so chooses, they're more than welcome to exempt legislators' childcare. I would still ask the committee to consider it for LSO, for our own staff. But I think it's meant to be a broad bill to cover everyone. I don't have any problem with the committee if it so chooses to exempt legislators from the benefit.
Representative Clauston.
Yeah, this may deal with the amendment as much as the bill. So when I worked for our hospital, we did the same thing in Gillette, and it was very highly utilized by employees. It's been a great program. So the question comes in is, we looked at to charge and make it a free benefit, or to charge. And the thought was, if we didn't charge, it was a benefit for some employees, but not to others. So, we ended up charging. What are your thoughts on the free for service or a fee for service?
Representative Yin.
So my personal thought would be to provide it for free, and I do understand the concerns from other employees who don't necessarily use the benefit, but there are a lot of benefits that are provided to employees that not every employee uses, including healthcare, for example. Not everyone takes advantage of their own employer healthcare because their spouse might have it. However, again, talking to a couple of state employees, that was a concern, so that is why I brought that policy option as an amendment to the committee.
Promise? No, Representative Trujillo, you can have a couple questions.
No, it's just a quick question. It's in the daycare would be in the Capitol complex. But would it be open to all state employees throughout Cheyenne? Say, for instance, somebody going over across town to work at Game and Fish? And can they, on their way to Game and Fish, drop their kid off at daycare here?
Representative Yin.
Mr. Chairman, that is the intent. Again, with regards to capacity, I think there would have to still be rules in place provided by ANI to determine what that looks like if a place is full and to give notice to folks. So if you had planned to do it, that they would be aware. But I do think the intent is to allow any Cheyenne area state employee to use it. Or state employees that come to town that need to have childcare for their own child to be able to use it as well if capacity allows.
Representative Chadwick, question?
Thank you, Mr. Chairman. As I read this, it would specifically exclude YDOT and Wyoming Game and Fish. In page 2, lines 8 and 9, it says state employees means employees of the executive branch, the judiciary, and the legislature. Am I missing something?
Representative Yin.
Mr. Chairman, it was my drafting intent to ensure that those folks fall under the executive branch. I think the people that would be excluded would be, for example, the school district, right? So in my mind, that doesn't fall under the executive branch, but if Game and Fish and YDOT don't fall under the executive branch, I would be happy to make sure those agencies get amended to it.
And I think it doesn't say general funded agencies, it just says executive branch, and so that should assumedly cover anything state level. Other questions, Representative O'Hearn? You're the only one who has one, yep. All right, anybody else, Representative Yin? Seeing none. People here to testify in favor or against House Bill 206. Mr. Lancy, welcome. Floor is yours.
Thank you, Mr. Chairman. Good morning, committee members. My name is Cindy Delancey. I'm the president of the Wyoming Business Alliance. What brings me here today is to talk to you a little bit about Representative Yin's bill as a tool that can help enhance workforce development in our state. My members struggle daily with ways to develop workforce and find employees. I know the state of Wyoming has also struggled for many years about filling vacancies, particularly after a lot of hard years of cuts, benefit reductions, and inability to find skilled people to fill the positions that to conduct the business of the state. So although Representative Yin's bill might not be perfect in its current form, I really like the sound of his amendment as to address the fee, no fee discussion. But, this is a trend that most big companies are going towards. And I just wanted to share with you a little bit of the research that I've done on why. Having on-site childcare helps people get back to work, in the time that they have to have an absence for illness or, maternity, paternity leaves. It provides a tool for employers to offer to their employees one less element of stress. It saves on commuting times, it increases productivity, keeps employers engaged, knowing that their child or loved one is right downstairs or around the Capitol complex. People want to stay. It's a retention tool. And so, I really applaud the effort that yet Representative Yin has done this. This is a step of modernizing state government. This is real. Childcare is probably the most, and healthcare are tied when you survey employees. Those are the most two important things that are meaningful to employees. So to kind of give the state a little bit of a competitive edge in filling some of these vacancies so they can conduct the business of the state, which ultimately benefits the business community, is really why I ask you to continue this conversation and explore this concept. So with that, Mr. Chairman, I'm happy to answer any questions.
Questions, so Wyoming Business Alliance. Representative Hornick?
Thanks, Mr. Chairman. I don't know if you know this or not, but with childcare, what's the liability that childcare services bear with children? I mean, do they have to carry insurance and all of that stuff for their company? I'm not aware of what that is.
Go ahead, Mr. Delancey.
Thank you, Mr. Chairman. Thank you for the question, Representative Hornock. Since this would be a governmentally run childcare, there probably would be some different mechanisms as if this was a childcare business in the private sector. Sovereign immunity would be in place, some of the governmental protections that, as government engages in a multitude of services. I'm unaware of any exclusion related for childcare. I assume that's the intent of Representative Yin in this bill, that of course all the licensure requirements by having, I believe Representative Yin mentioned Department of Family Services oversight, obviously that all would not be different because it would be a governmental service.
Further questions? Seeing none. Thank you.
Thank you.
Other people here to testify on House Bill 206? Welcome, Betty Jo. Floor is yours.
Oh, thank you. Good morning, Mr. Chairman and members of the committee. I'm Betty Jo Beardsley. I'm the Executive Director of the Wyoming Public Employees Association, representing all state employees. And we work every day trying to find ways to recruit and retain employees. This would be an avenue, but I can see that we need to really work this, make it a topic to discuss. You've got state employees that work like shifts into the night. And so, is it gonna be a 24-hour service? Daycare, I can see where some instances might eliminate some people being able to utilize it for that reason. And I can tell you, if we get it here, I hope we get it for every place in the state, especially for like employees over in Evanston at the Wyoming State Hospital, in Lander at the Wyoming Life Resource Center. Everybody could utilize a benefit like this, and it would help recruit and retain employees.
Okay, further questions for Betty Jo? Representative Hornock.
Thank you, Mr. Chairman. Do you have an idea of what the need is? How many employees do you think would utilize this? How many employees right now utilize daycare services? Generally, we're talking here in Cheyenne, so kind of here in Cheyenne, do you have any idea of what the numbers would be?
Mr. Chairman, Representative Horn, I don't know for sure, but I can tell you, your common work day is like 8 to 5. And there are sometimes, like I said, people work a different shift in that 8 to 5, and they're like until 6 or 7. But at the regular daycares in your community, there's that responsibility of having your children picked up by 6. If we had something like this that went in to the evening hours, I think it would be utilized a lot more than we would know. Now, as far as a number, no, I don't know, but I do know that we have been contacted from a lot of different of the facilities that are in state government. Like I said, the Wyoming State Hospital and the prisons and Department of Corrections for daycare. And all of those facilities have employees that work 24 hours. There's at least employees working, around the clock. So I wouldn't have any idea. It would be something worth looking into as far as a survey to see, you know, who would utilize it. Would it be that you'd want to put them in every day, or would you want to be able to like utilize it when one of the prime examples I can think of is when COVID started, my own secretary, when school was closed, she was going to take her little boy to the Boys and Girls Club, but it was closed. So I think the need is there, and I think we would see if we offer something like that, that a lot more would utilize it than we actually realize.
Follow-up?
Yeah, just a quick follow-up. So one of the thoughts I had with this, and it was mentioned sovereign immunity. So somebody's not allowed to sue the government. Do you think any employees would have a problem dropping their kids off in a daycare facility that they're not allowed to sue if there's a problem, or, you know, that it kind of releases the daycare facility from all liability when handling these kids? Is there an issue, you think, with that?
Go ahead, Ms. Beardsley.
Mr. Chairman, Representative Hornak, I don't know. To be honest with you, I don't know.
Other questions? Not seeing any. Thank you very much, Betty Jo.
Thank you.
Other people are here on House Bill 206. I know we have Director Schmidt online. Corin, we'll give you the floor for a bit if you want to talk about House Bill 206.
Good morning. Can you hear me?
We can.
Okay, it's not allowing me to start my video because the host is blocking it.
We would never block the executive branch. Give us just a second. We'll see if we can figure it out, but go ahead, and if we can get it working, we will. Perhaps we didn't set up the Zoom to be able to allow video, because I don't see it as an option to select. But go ahead, floor is yours. Most of us remember what you look like.
Thank you, Mr. Chairman. And good morning. My name is Corin Schmidt. I'm the director of the Wyoming Department of Family Services. I believe Roxanne O'Connor is there as well. She is our support services senior administrator, and her responsibility includes childcare and childcare licensing. I wanted to be here just as a resource to you, but there have been some questions that maybe I could take a chance to clarify, if that's okay, Mr. Chairman.
Yeah, certainly, Director. Floor is yours for as long as.
Thank you. Specific to a couple of the Representative Warnock's questions, one was about numbers. And I don't have the statewide or the Cheyenne-based state employee numbers, but from our agency, from the Department of Family Services in Cheyenne, we have about 150 staff. So that includes our local DFS office and our state DFS office. And to represent our agency, we are in an agency that's primarily staffed by women and a lot of younger women. So in regard to need, I can't tell you exactly what the need is, but the demographic that we recruit and that we really try hard to retain is the population that would be likely served by this facility. You also asked about licensing and the governmental immunity. If a child is harmed in any childcare facility, a report is made to not necessarily our licensing, although I would hope that happens, but primarily to our investigative unit for child protection services. So even though there's governmental immunity, that doesn't necessarily mean that the person who maybe committed the harm is immune. So if there was harm, if there was some sort of abuse and neglect, certainly the person, the perpetrator would be investigated, and then whatever the case may be with that. I would hope that the facility would be certified and licensed. It would be the intent. I think that provides everyone with the peace of mind. But certainly we would be available to provide any type of assistance to the Department of Administration and Information, who would be responsible for this, and anything else that would be asked of us. So thank you, Mr. Chairman.
And while we have you, Director, could you talk just a little bit about when it says a certified childcare facility, what that means?
Certified or licensed, we kind of use those terms interchangeably. So under the statute, there's a list of types of providers that are required to be licensed by the Department of Family Services to provide services. This includes childcare centers. It also includes residential treatment centers, some of the 24-hour facilities that serve youth and adolescents. So when a particular childcare center, and there are different kinds of childcare centers, is licensed, what that means is that they must comply with the rules that we have listed in order to provide services. It includes health and safety. It includes certainly physical space. It includes ratios. It dictates the types of training, such as CPR. There's other kinds of safety like background checks. But there's a set book of regulations that would say this is what you would need to do, childcare provider, in order to be licensed.
Further questions for Director of DFS? Representative Clausen, go ahead.
Thank you, Mr. Chairman. Hey, just a quick question. Do you think DFS would be a better place to manage and handle this department, or the current department that's been specified?
Director Schmidt, and in the bill, just so you know, it's A&I General Services currently specified.
Yeah.
But thoughts?
Mr. Chairman, Representative, I really do not have any specific thoughts about it. We would partner. We work very well with A&I one way or another.
Okay. Further questions? Seeing none. Thanks for being here, Ms. O'Connor.
Yes.
Anything
Thank you.
additionally while you're here? Just here to supervise in person? Okay. Yep. Anyone else here on 206 Medicaid? No? Okay. No one else online here on House Bill 206? Let me check the room real quick. Raise your hand if you want to talk on state employee childcare. Seeing none, we will close public comment. Committee, what's your pleasure on House Bill 206? Moved by O'Hearn.
Second.
Seconded by Chadwick. Are there any amendments, committee? Representative Yen, if you'd like to talk about yours at this time, please.
Mr. Chairman, yes, thank you. I'll move the amendment just for discussion. I think it's useful, and if it is the committee's will, I'd be happy to run with it.
So Chairman Yin, just to explain it one more time, this would allow fees to be put in place or no fees depending on what the study came back at and recommended, or would allow for fees at any time. You just go through a little bit more.
Sure, Mr. Chairman. So to go through the amendment, the first parts really just kind of modified to ensure that it's cost of providing. So on page 3, line 13. So we're talking about that will be in the cost of providing is also under the department's responsibility. And then we talk about fees charged under on the amendments, lines 13 through 18, go towards the cost of the actual providing of childcare. And then on lines 24 to 28 on the amendment, the fee schedule is adjusted to reflect the prevailing market rate. So that's the part of how the prices are set. It's just the market rate for daycare in the city of Cheyenne. And that's essentially it.
Any questions on the amendment? Representative Ward.
Thank you, Chairman. It says in line 10, it says delete provided at no cost and insert offset by fees charged to. So to me, when a thing says offset, it doesn't mean covered fully. Is that correct?
Representative Yin.
Mr. Chairman, because the fee schedule is set by the prevailing market rate, it's not 100%. It's not 100% guaranteed that those market rate fees would offset the cost of providing it. My thought would be that if a business could provide it at market rate, then it's likely that it would fully offset the cost. If we would like it to fully offset the cost, that's an amendment that I would be also happy to work with Representative Ward to bring on the floor.
Further questions on the amendment? Representative Hornock.
Thank you. So one of the issues we heard in bringing this item to the table to look at is to kind of increase the compensation and benefits for state employees. So if we're trying now to offset our cost, what's the difference with that employee just going out to a regular daycare provider outside of what we're trying to do here and paying there versus paying here? I don't see how that would benefit what the bill is kind of intending to do. Thanks.
Go ahead, Representative Young.
Mr. Chairman, thank you, and maybe I can lean on Representative Closton to talk about his experience with the hospital in Gillette, but a lot of it just is the consistency and reliability of the availability of childcare. So I talked with a couple of state employees in the Cheyenne area, and I heard a story where, one, it's almost impossible to find childcare facilities that are available, especially for that 1 to 2 year period, the first and second years. The 3 through 5 tends to be a little bit easier just because they're bigger kids, and so there are more facilities that have room for those kind of folks. And then some of those child care facilities only give 30 days notice before they decide to remove a kid from their facility, and having 30 days notice and then trying to scramble for something while you're still working a job and your spouse is also working a job makes it very difficult. And so that benefit of just providing the availability and reliability of a center that's available and also in a convenient location that's near your work it is still a benefit even at cost.
Questions on the amendment, Representative Klaus?
Not a question, just a comment to go off. Thank you. We saw it as a huge benefit in hiring and retaining employees, like just having the proximity to your child if they were sick and not having to travel across town to daycare, and having daycare available was a huge benefit for these employees. Also, the hours are extended a little bit longer. So if an employee has a meeting or a commitment that runs past 4:30 or 5 o'clock when a lot of the other daycares closed, was also a benefit. So we saw it as a huge plus to the facility and to our employees. We did make them pay though, but just for what I talked earlier, people can choose to take or not take healthcare, but if you don't have kids that fit this category, it's not a benefit for you. So that was our decision in that way.
All right, any other discussion on the amendment? Representative Penn.
Thank you, Chairman. So this is a topic that's near and dear to my heart, childcare. Being a working mother with 3 kids, ages 3, 5, and 7, this is big for me. And because of that, I've been in the position where I've had to look at not working because I can't find childcare. I have looked at starting my own daycare. I've petitioned my employer for years to try to start a daycare. And these are the issues that I run into. And these are the issues that I struggle, the reasons why I struggle to find daycare. The issue is the regulation of these daycares. That's why people are having difficulty getting daycare. In our own town, we've had about 5 or 6, and this is no small town, 5 or 6 daycares go out that would cover probably a couple hundred kids. We've had people move out of our county, because the lack of daycare. I struggle with this bill for several reasons.
We are still on the amendment
Yeah.
right now, just making sure.
Okay, so the cost is what I'm getting at with this amendment. When it talks about fees offset, the cost of this is gonna be astronomical. Even if parents are paying to help offset those costs. That's what I've run into in my own facility. They want to provide that service, but the cost to them is so great that even if as a parent we're paying for that, it's still a great cost to them. So my comment.
Further questions on the amendment? Seeing none on the amendment, all those in favor say aye.
Aye.
Opposed, say no.
No.
That amendment passed. Further discussion on House Bill 206, committee. Since I don't know exactly sensing where this bill's going, I would have some amendments, but if it gets through, I can make them on the floor and we'll figure it out then. We have Representative Ward, go ahead.
Thank you, Mr. Chairman. Just want to make a comment. In my view, this grows government, and I'm not for growing government, so I'll be a no. Thank you.
But it helps children. Representative Penn.
It does help children. And like, you know, to follow up on what I started saying, with this bill specifically, I love the intent because again, this is something that I struggle with on the regular. We're way early. There's a lot of work that needs to be done here. You know, the mention of where are we gonna have this, that in and of itself could take an interim. You know, it was brought up that maybe there's a couple unused rooms in the complex. What we're talking about here would require its own facility. The regulations that would be imposed, that would come with this number of children and the number of kids that we would, if we were to poll our current employees, it's not doing justice to the numbers because once again, this is going to be used as a recruitment and a retention tool. And so people, if you're offering daycare, whether it's free or not, people are gonna come. So that is a benefit. Do I think it's a responsibility of government to use taxpayer dollars to pay for other people's childcare, especially when it's not being offered to all? I don't. But we're talking about commercial kitchens here. We're talking about addition of many employees because the ratios, the staffing ratios that are required for regulation are very closely monitored and very intense. There was a comment made about, I hope this is a licensed facility. There's no way this could happen if it wasn't a licensed facility, and that brings a lot of regulation. If we want to look at fixing our childcare issue, and we should, we need to be looking at those things. Why is it that our current private facilities are not able to provide services? Why is it that they're going out? Because people want to do it. I've approached many women and they always say, you know, I used to do this, I love doing this, I want to do this, I can't do this because of this, because of this, because of this. I've been dropped from, my kids have been dropped from about 3 different daycares for regulation reasons. If I have, new regulation says if I have this many kids, I have to have a commercial dishwasher in my home. So I have to drop the number of kids that I have. That's what we need to be addressing here. And unfortunately, this bill just misses the mark.
Further comments? Okay, Representative Yin.
Thank you, Mr. Chairman. So I hear Representative Penn loud and clear, and I have other bills that will help with that. It won't deal with necessarily the certification and licensing regulation. I think that is definitely something that we should hear over the interim to see whether it makes sense to overhaul those. There is a lack of daycare in the state of Wyoming, not just Cheyenne, but the entire state. I know my constituency, I would love for their state employees to be able to have accessibility to this daycare or have accessibility to daycare at all, because we have so many of the families in my district have 2 working parents and no place for their child to go, or even thinking about whether they want to have a child or not, because if they have a child, that means they'll have to deal with daycare, and they see what the other parents have to deal with regards to daycare. I don't think that, I think the problem is worth tackling with regards to daycare across the state, but I don't think that's a reason to say that this bill is a bad idea either. I think all of those problems should be and can be addressed together. That doesn't mean it's a reason to not try to do the best thing that we can do for our state employees right now. So thank you.
Okay, with that, Marilyn, if you'd call the roll on House Bill 206.
Representative Chadwick,
Aye.
Representative Klauston,
Aye.
Representative Hornock,
No.
Representative O'Hearn,
Aye.
Representative Penn,
No.
Representative Trujillo,
Aye.
Representative Ward,
No.
Representative Yin,
Aye.
Chairman Zwanitzer.
Aye.
The vote, 6 ayes, 3 noes. The vote passes.
All right, Representative Yen, I assume you'll carry that on the floor.
Yes, Mr. Chairman?
And, you know, for my advice, you might want to make it a budget amendment too before putting all of that code and statute somewhat prematurely. But best of luck on the floor with that one. All right, with
Thank
that
you, Mr.
committee,
Chairman.
Representative Berger, welcome to Labor Health. We're happy to see you. House Bill 122, anesthesiologist assistant licensing is up next. Come on forward. The floor is yours to present House Bill 122. And Ms. O'Connor, thank you. Always a pleasure seeing you. We look forward to your hanging out with us in the interim.
Mr. Chairman, members of the committee, thank you for having me here today. Appreciate it. It's been quite a last couple of days, but it's been wonderful. I'm excited to be here, and I apologize for being late this morning. But here we are. I bring you, Mr. Chairman, House Bill number 122. And this is a bill that a constituent of mine has a daughter that is an anesthesiologist assistant in another state. And he was talking to me about that in our hometown. And we don't have licensing and provide for licensure for anesthesiologist assistants in the state of Wyoming. We got talking, and I found out that this bill, through many meetings, that this bill has been here before in the Senate, and I reached out to Senator Pappas, who was going to run this bill, and I asked, could I do this as my first bill and try it out? And so I resurrected this bill out of the files from 2021, I believe, and bringing this back and bring out the discussion, because I found in my research, I found out that there are a few former Wyoming students and residents that have gone out and gotten their anesthesiologist assistants, and they can't come back to Wyoming because we don't have licensure for that. So this is why I bring you this bill. So, Mr. Chairman, with that said, can I walk you guys through the bill now?
Please do. That'd be great.
All right. Thank you, Mr. Chairman. So here we go. We look at page 1. This is, again, an act that's relating to professions and occupations, obviously providing for licensing for anesthesiologist assistants. So again, line 12 on page 1, be it acted by the legislature of the state of Wyoming. So section 1 provides this, the statute, Wyoming statute 33-26801 through 33-26811 are created here to read. All right, so these will be created. So we start obviously on page 2 with the definitions. I can go through each definition, but I'm hoping that we all get that right.
I think you can
We're
go
good.
through cursory.
So we got that
Joel, and we'll
section of
ask.
definitions here, which is just awesome. Thank you for not making me read everything. I appreciate it. I was in a car accident last night, so I was kind of weary. So a lot of people were texting me, and I didn't, but I'm okay. The other person's okay. We're good. So but thank you for not letting me. The next one, again, is the scope. So obviously scope is what they're allowed to do, right? Through their education and all that. So we provide the scope. And we know that in scope, if this passes, that the hospital could decide how many of these practices they can provide, or will let the anesthesiologist do, but this is what we would let them choose from. And this comes from all their work and their licensing and their boards and their school and their training and all that. Okay, that's where the scope comes from. We create a board of powers and duties for licensing. The board shall, on page 11, so if you look at A, the board shall review qualifications and determine the fitness of all persons desiring to practice as an anesthesiologist assistant. So we got we go through the board and what they're doing as far as licensing and licensure, all that stuff. Then we go to the next section on page 14, the license, this is the required, the application, the qualification, consideration of applications. That's all explained there in that section. Next section is temporary licenses. We add that, that's part of the common practice with states that have this. And we also offer in the next section on page 17, the terms of licensing and renewal process. So we got that provided in here. Licensing fees, all the fees that it takes for anesthesiologist assistants to be licensed. Page 19, we talk about denial or suspension or restrictions, okay? All that stuff through that section. And then reinstatement of a licensing if when he wants to come back and get reinstated, similar to what we do with all professionals. We got penalties on page 24, page 25. That section is voluntary and mandatory revocation, restrictions, and suspension. And then at the very end here, that we have a few definitions. And then as it goes through the bill, we have a few definitions. And the only thing that we added to this with LSO is the definition of a CAA-HEP, which means the Commission on Accreditation of Aligned Health Education Programs. And the one below it was the old one, okay? And so, but the CAA-HP now, they put the one below it because all of those accreditation people are now into the CAA-HEP, okay? And that was just the only thing that the LSO said that we needed in the bill to really kind of conform what we're doing. There's several people online. Mr. Evans is here with us today, and I believe Brandy Lunsford, she is again a former student athlete of mine. She's the anesthesiologist assistant in another state, and she's gonna help me with this bill. But Mr. Evans he's the Director of Government Affairs for American Academy of Anesthesiologist Assistants. So he helps states in this process with legislation. It's a very common bill that's pretty much what all the states that have accepted this are doing.
All
Okay?
right, we'll get to Mr. Evans.
So anyways, Mr. Chairman,
Yep.
that's all I have. I stand for any questions, but the questions, if you have them, I would hopefully refer to Mr. Evans or Brandy. There's been a lot of emailing. I appreciate Representative Penn and her questions for Mrs. Lunsford, and I appreciate all the work you've done there. So I'll stand for questions, but if not, I'll turn it over to Mr. Evans. Is that okay, Mr. Chairman?
I'll let you know. Any questions
Okay.
for Representative Berger? Representative Ward, go ahead,
Yeah.
and then
Thank you, Mr. Chairman. So as I read this bill, and correct me if I'm wrong, an anesthesiologist assistant cannot practice by themselves. They must be working with an anesthesiologist. Is that correct?
Correct.
Representative Berger.
Yep.
So
Follow-up?
then,
Mr. Chairman.
follow up?
Follow up, Rep. Ward.
Thank you, Mr. Chairman. So help me respond to the argument that this will only increase costs of care because an anesthesiologist assistant cannot practice on their own. They have to be supervised by an anesthesiologist. Therefore, there's going to be two people in the operating room. It gives a chance for providers to increase the billing or the cost of providing services. So help me respond to that.
And Representative Berger, if you want that, or we can turn it over to a future presenter if you'd like.
Mr. Chairman, I appreciate that question. Those people online can answer that better than I can, but for my answer is, The anesthesiologist is on site at the hospital, their assistants, and they're performing those duties just like they are. They can be in their own operating room, as far as I know, but those people online, Mr. Evans can answer that even better.
Okay.
Appreciate those questions.
Questions, Representative Berger, Representative Chadwick.
Thank you, Mr. Chairman. You alluded to this bill being resurrected. Could you allude to why it failed in the past? What was behind that, if you know?
If you know, Representative Berger.
I really don't know. Sorry, Mr. Chairman, Representative Chadwick. Appreciate that question. I know it's been in the Senate and it's been in others. It's just cleaning up, as far as I know, it's cleaning up the bill, making sure it's right, making sure it has all the right components of the bill and that we're licensing it right. That's about what I know right now. And anyways.
Follow?
Follow-up, yes.
Yeah.
So you said
Mhm.
Representative Berger.
Yeah.
Get my thoughts straight here. You mentioned that you got the bill right. You made some changes. Could you allude to those changes for us?
Representative Berger, if you know.
Mr. Chairman, Representative Chadwick, really, it's just some definitions. It was just two definitions on the back, of the very back on page 26, and making sure that that the CAAHEP was there and that was defined. And then also the other changes is just educating everybody about what anesthesiologists do and the people who are online and what they can do. And there's misconceptions about anesthesiologist assistants compared to nurse anesthetists, all that. And I think it's why we resurrect bills is just continue learning about this. Obviously every bill doesn't go through the first time. It takes a few times to get through. And part of that is educating all of us about what these people do. In this case, it's about educating you guys, all of you, Representative, about what anesthesiologist assistants can do and what their licensing is about and how they can help and provide for patients in Wyoming.
Thank you.
Okay. Another question, Representative Clausen.
Thank you, Mr. Chairman. Representative Berger, so with this, I'll be curious what kind of other support you've had. So I've had one anesthesiologist reach out to me who's in favor of this. And I've had several surgeons reach out to me who are not in favor of this. They don't feel these people are qualified to work on their patients. So I was just wondering what kind of support you've got from agencies or other physicians outside this specific group of assistants.
Go ahead, Representative Berger.
Mr. Chairman, Representative Clausen, exactly right there. I haven't had any doctors talk to me about these guys, but I've had other anesthesiologists that practice in Wyoming that said, this would be great. We want this. We've ran this before, and they would like them to work with them. We do have anesthesiologist assistants that do work in Wyoming. They work at the veterans, the VA hospitals. Those are federal, and the federal government allows them there. So they're working already, but they only work at VA hospitals. And from what I found and what I found in my research, they're no different than they work hand in hand with anesthesiologists and nurse anesthetists. They're in the same operating rooms. They're working together. I think there's some misconceptions there that are they truly qualified? Are they not? And one thing I remember looked at this as I looked at it, and I asked these kids, why didn't you just become a nurse anesthetist? Why didn't you just do that? Well, there's two paths. A nurse anesthetist is working on a path to become a nurse, right? And they find out that they like anesthesiologists, so they get licensed there. And anesthesiologist assistants, they were going to school to become doctors, okay? and they were on the path to become a doctor, and they, when they took the MCAT, started taking classes, what they found is they liked anesthesiologists, and how do I want to say, passing gas. Anyways, Mr. Chairman, so they like that. So for them to be this assistant, that's what they wanted to do. Does that make sense? So that's the misconception that we're trying to find, is educating everybody, whether this group is better than this group or where we're at. And that's what I'm hoping that Mr. Evans and the people online can explain to you, what their training is like. And as I look at it, they're very highly qualified, and they're very good at their craft. Thank you, Mr. Chairman.
With that, we do have about 8 people here to testify on this bill. So let's go to Mr. Evans first online. Mr. Evans, we're not, it does look like maybe the cameras are back working now. So the floor is yours. If you'd give us about 4 to 5 minutes and some time for questions to talk about what this bill might do for Wyoming. But you're muted.
Okay, can you hear me now?
Yep.
All right, thank you, Mr. Chairman and members of the committee. Yeah, my name is Richard Evans. I'm Director of Government Affairs for our national organization for anesthesiologist assistants, the American Academy of AAs. And we've got a couple of folks also that are certified anesthesiologist assistants that are going to testify as well, that are with our state academy of AAs. I can address some of those questions that came up. Let me give a quick overview of the profession though, and education and training, and then I'll get to the questions that were posed there. And I know that, in some states, licensure is used as a barrier, to entry into the market. For the AAs, it's really it's the pathway to entry into the market. We can't practice in most states without being licensed. I'm from Texas, and in Texas, we have delegatory authority, which means the anesthesiologist can delegate responsibilities to an unlicensed provider. So we have about 250 AAs practicing here, even though we don't have licensure. But that's kind of rare. The other we practice in 19 states, and 15 of those states require licensure. So that's typical. Appreciate Representative Berger laying out the bill. He did mention creating a board in the bill, but actually it's where we would be licensed under the medical board, which is the case in every state where we practice, except for Georgia, where we're under the physician's assistant board. CAAs have been around for about 50 years. The program was created back in the late 60s by some anesthesiologists who back then saw workforce shortages and a need to add more anesthetists to into the workforce. And AAs, as Representative Berger mentioned, get their undergraduate degree in any particular field, but they have to take all the same prerequisites that you take for medical school. The programs require an MCAT or the GRE in order to get into the master's program. AAs are trained to perform the same functions as certified registered nurse anesthetists, but the major difference is that the AAs always work under the medical direction of an anesthesiologist and what's called the anesthesia care team model. And you actually have facilities in Wyoming that operate with an anesthesia care team, where you have the anesthesiologist as the lead of the team, and they can supervise up to 4 anesthetists in that model, according to CMS plans guidelines for Medicare. So we do have authority to practice in 19 states, the District of Columbia, and the Territory of Guam, so 21 jurisdictions around the country. AAs have been providers in the Medicare system for many, many years. State Medicaid programs, all the commercial insurance companies cover services by AAs. And as Representative Berger mentioned, the AAs can work in any VA hospital in the country. We actually don't currently have anybody working in Wyoming. Just to clarify that, we've got a couple of AAs working in the Veterans Administration in a couple of states, but we've been hampered there because the GSA pay scale is about a third of what the market pays for AAs. So, we're trying to work with the VA to get that pay scale issue resolved so that more AAs can work in the VA hospitals, but we can work there regardless of whether or not the state has licensure. So AAs work around the country in major university hospitals and level 1 trauma centers, children's hospitals. We've got 15 accredited programs around the country, all associated with medical schools. We've got about 3,300 AAs that practice in the US, and that number is expected to double by 2033. The master's program is about 24 to 27 months. It's about 2,500 clinical hours and a combination of classroom and simulation study, but a lot of rotations in the different areas of the hospital to get your clinical rotations. And then the AAs, once they graduate from their program, they will take a national certification exam and have to pass that exam in order to be able to practice, and now have to take that exam, that recertification, every 10 years and have to do 50 hours of continuing medical education every 2 years. You know, in most states, we're seeing workforce shortages, and really this is not an either or situation. Hospitals need to have the ability to hire both. And in the states where we do practice, AAs and CRNAs, you work in the OR interchangeably. Their privileges are exactly the same in those hospitals. They perform the same function. We have 1,000 AAs practicing in Georgia. Emory University was the first AA program, so that's why we had so much growth there. And, you know, I'd like to say we also, you know, don't propose to be the solution in every area of the state. In Wyoming, got a lot of rural areas. You don't have a lot of major hospitals out there. But we can practice wherever there's an anesthesiologist. And when there is in those rural areas, we can really be a workforce multiplier because the anesthesiologist can supervise up to 4 AAs or CRNAs. And by having more, you know, availability of the workforce, we think that we can help, you know, alleviate some of those workforce shortages. I'll just hit on a couple of the questions that came up, and then happy to take any others. But to Representative Ward, on the issue of the cost of AAs, there isn't any additional cost when you're talking about what the payer is paying. So CMS rules, which are for Medicare, which really are used by hospitals for all their payers. The way it works is there are different billing codes for anesthesiology. And if an anesthesiologist is personally performing a service, then they would bill one code and they would get 100% of the payment, or actually the hospital would bill for it and get 100% of the payment. If a anesthesiologist is supervising an AA or a CRNA, the rules for Medicare apply to both. We're defined as non-physician anesthetists, exactly the same as CRNAs under Medicare rules. But if they're supervising an AA for that surgery, then the payment would be split. So the hospital would bill for a different code, and the payment would be split between the anesthesiologist and the AA. And back when AAs were added to the TRICARE system, which is for active military personnel, this happened many years ago, but DOD was asked if this was going to raise cost, and their response to that was no. They stated that, you know, the payment for anesthesia services provided by an anesthesiologist and AA under the anesthesiologist direct supervision will never exceed what would have been paid if the services were provided only by the anesthesiologist. So for the payer, there's no difference in whether you have an AA working under the direction of a physician or if you have a physician providing those services directly. 100% of the payment or it's split. As far as the cost of the facility, you know, that's their decision whether or not to employ AAs. And that's all we're asking for is just the opportunity to get a license there and work. But the ability of the physician to be able to supervise up to 4 CRNAs or AAs gives them the ability to do more surgeries. So if there's an additional cost for the staff, you know, for the hospital, then that is made up by the fact that they're actually able to handle more of the surgeries. And I know that in a lot of places we're seeing backlogs of surgeries that haven't been delayed because they don't have the appropriate personnel. And then to Representative Clausen's comment about the surgeons being opposed, we see that, I mean, the only opposition we see in states is from the CRNAs. And honestly, their public policy arguments don't really hold much water. But in states where we don't have licensure, the CRNAs are the only other anesthetist in the state that the anesthesiologist can work with and that the hospital can hire. So they have a monopoly. So they're completely opposed to this. They do get some surgeons to come out in opposition, surgeons that would probably never work with an AA. But if that surgeon is going to have an AA in the room, they're also going to have an anesthesiologist who's directing the care. So, we do see that because the CRNAs are, predominantly, in those hospitals, and they're able to get some of their staff who don't know what AAs are, have never worked with AAs, to come out in opposition. But the Society of Anesthesiologists there in Wyoming is strongly supportive of this bill. I have requested a letter from the state Society for Surgeons to see if we can get their support. They typically support wherever they have a chapter in a state. They will lend a letter of support to the bill as well. And this is not like your typical scope of practice where you have an ophthalmologist fighting against optometrist. The anesthesiologists, if they were opposed to this, that would be a problem, but they're not. They're our strongest supporter. The American Society of Anesthesiologists strongly supports our efforts to get more personnel into the states, because they're seeing that their hospitals are just not able to handle the load that they have with the current staff that they've got. And they'll have job postings sitting out there for months waiting for people to be hired. So I'll stop there and see if there are any other questions. Sorry, I know that was more than 5 minutes. I apologize.
Representative Ward, question.
Thank you, Mr. Chairman. You mentioned that with Medicare, the cost can never be higher than it would be with just an anesthesiologist. But does that also apply to private billing? So not Medicare, so private insurance?
Yeah, so Medicare billing rules are just commonly adopted by hospitals regardless of payer. So the payers are all going to use that same methodology for payment, same coding and billing guidelines. So yes, ma'am, it would be the same applicable to commercial, Medicaid, whatever the payer is.
Okay. All right. Representative Penn, question.
Thank you, Chairman. Could you please offer me some clarification on a couple of things that you said that, so you mentioned that that payment would be split between an anesthesiologist and an AA. Later, though, you said that there would be an anesthesiologist in the room, and otherwise you said that this would offer people or offer facilities more opportunity to do more surgeries. So I'm not sure how this offers more surgeries to a facility if the anesthesiologist and the CAA have to be in the same room. Thank you.
Yeah, glad to clarify that. Thank you, ma'am. So the way that the supervision works, the billing term is called medical direction. And under medical direction, the anesthesiologist can supervise up to 4 AA, CRNAs, or a combination. So instead of having to personally perform the anesthesia and be in the room the entire time with the patient, being able to have an anesthetist that's actually performing a lot of the service allows that physician to supervise up to 4 rooms. So they have to be immediately available. They're in the operating suite, but they may have 3 or 4 rooms with patients going where the AA is in there performing the service, and they're coming in to supervise and make sure things are fine. They're available if there's any kind of issue that they need to get called in for. So it does expand the number of cases that you could handle concurrently. So instead of having one anesthesiologist, one surgery going, you can have one anesthesiologist and 4 surgeries going. And that's what CMS rules provide, whether it's an AA that's being supervised or CRNA or a combination.
Okay, further questions?
Could I have one follow-up?
One follow-up, yep.
So what about, is there specific procedures that do require direct oversight for a CA? So tell me about induction and emergence. Can they do those without the anesthesiologist in the room?
Yeah, I'm going to let the AAs kind of speak to the more clinical aspects, but I would say that the CMS rules used to require induction and emergence. This was many years ago, said induction and emergence were required to have the physician present. They changed that rule to say, if applicable. And so, it depends on the patient and the acuity of the case, I think. And those are clinical decisions that the anesthesiologist would make. But there are steps called TEFRA steps that are required when an anesthesiologist bills for medical direction, and they are required to be present for the most demanding aspects of the case. And that's as much as they have defined it in the CMS rules. I know that's kind of broad, but they do need to be personally present and involved in the parts of the case that are the most demanding parts of the anesthesia care plan. And That's going to depend, I think, a lot on what's being done, what the case is. Not every anesthesia case has induction and emergence. So there are, cases that don't require that. And I think that's why the CMS guidelines are pretty broad on that point. And then I'm sorry, I didn't answer the one question about the billing. We say it's split between the anesthesiologist and the AA, but it's being billed by the hospital. The hospital's collecting the fees. The anesthesiologists and the AA are employees of the hospital, so they're not getting they're not billing directly to Medicare. They're not being reimbursed directly from Medicare. So it's either the group, there's an anesthesia group that works with the hospital, or it's the hospital doing the billing.
All right. Thank you much for being here, Mr. Evans.
Thank y'all.
Mr. Bonablest from Board of Medicine, or hit some state agencies. Floor is yours. Welcome, Kevin.
Thank you, Mr. Chairman. Are you able to hear me?
We are.
Great, thank you. My name is Kevin Bonablest. I'm the Executive Director of the State Board of Medicine, which licenses and regulates practice by physicians, MDs, and DOs, and also physician assistants. And we would be put in that position then with AAs were this legislation to be passed. First, let me say I apologize for not being there in person. The board's having its quarterly meeting today in the next room over. And so I kind of had a full dance card today. So I hope you'll forgive me for not being there. I don't have a lot to add about this bill because, well, first off, it's not a bill that we brought. And so, I'm here to answer questions as much as anything. I do want to point out that this statute or this bill was taken pretty much from the existing physician assistant statute. And so it really parallels that. And so I think that's a good sort of a comparison. And, physician assistants and nurse practitioners, kind of an equivalent there in various ways. And similarly, then that would bring in the AAs if this bill passes. And so then there would be an advisory council created to the board, as there is with PAs now, so that the licensees are able to have a voice in, reviewing applications for licenses and involvement in the rare disciplinary cases that might occur. Beyond that, I don't have a whole lot, except I do want to make a quick comment. I've been doing this for a lot of years, and I still haven't cracked the code on how to get a good fiscal note written, apparently, because the fiscal note on this bill indicates that we're going to get a little bit of revenue, which is true, but it doesn't indicate that there will be some cost to the board in terms of setting up. Everybody wants online forms now. We have to have a licensing system where people can look up licensees and so on. So we're going to have about $48,000 in costs the first year, which won't be covered by the licenses because there's not going to be that many. And so, whether we get it by an appropriation or we go through a B11, we're going to need that to be able to set things up. And someday, like I said, I'll crack the code on how to actually get a fiscal note to read the way it should. But with that, Mr. Chairman, I don't have anything to present, but I would be happy to answer any questions from the Board of Medicine perspective.
Question for the Board of Medicine, Representative Penn.
Thank you, Chairman. Could you elaborate a little? You said that there isn't going to be that many CAs practicing. Do you have an estimate as to what we would be seeing here?
Director.
Mr. Chairman, Representative Penn, what I did was in creating this, I basically looked at, we also looked at one point at surgical assistants. There was a bill for that. And we looked at similar numbers in, say, Colorado and so on, and scaled them down for our population. And so that's my best guess on those numbers. Now, just to give you an idea of how bad my crystal ball is, when the legislature was looking at the Interstate Medical Licensure Compact, I estimated that probably 10% of our licenses per year would come through the compact to issue new licenses. For the last 2 years, it's been 46%. So I way lowballed it. But whether it's large numbers or small, we'd certainly be able to accommodate it. It's 1 or 100 would be pretty much the same process for us.
Okay, further questions, Representative Hornock.
Thank you, Mr. Chairman. Are AAs currently operating in Wyoming? Are they allowed to? Are there places where we have those throughout Wyoming right now?
Kevin.
Mr. Chairman, Representative Hornock, at least not practicing as an AA per se. there is something, there's a long-term tradition in medicine that physicians can delegate authority to non-physicians to perform tasks. And then it's sort of up to the physician to make sure that person is doing it properly and so on. And the physician's license is in the balance at that point. But understand that with surgery and that sort of thing, there are stricter requirements that I'm sure that Representative Clouston could speak to far better than I, that they've got requirements for credentialing anybody who comes to work for them. And I doubt that they would allow an AA at this point to be just delegated authority by a Wyoming anesthesiologist. So I don't know that there are any. I don't believe there are any. But and the other thing too is the nuances on payers is that payers generally don't pay unless somebody's got a license. They don't pay for a professional fee unless it's a licensee. And so that's part of the reason for this too, is that until there's a license, most likely most payers would not pay for the service, even if a facility would let them in.
Okay, other questions for the board? Seeing none, thank you for being here.
Thank you, Mr. Chairman.
Other state agencies, nothing, Michelle? Enjoying the weather outside today? It's a little cold. If only we were somewhere nice and warm. Hospital Association, anything? Or no other agencies are online, so going to groups. Nurses, do you have something? If you do, come on down. We'll get you next. Welcome, Josh.
Thank you, Mr. Chairman, members of the committee. Josh Hannes with the Wyoming Hospital Association. We spoke with the sponsor of this bill yesterday and don't really have much to offer, maybe just a few suggestions. So we've spoke with our members. I don't know that a lot of our hospitals would take advantage of this new opportunity to hire this particular licensed professional into their facilities. We have a shortage of anesthesiologists in the state as it is to supervise. A lot of our hospitals don't do surgeries or deliver babies, things like that. So I just don't know that there's a lot of opportunity. But if this were to go through, hospitals that didn't want to participate could manage that through their medical staff bylaws and create the conditions under which they could or couldn't provide service in their facilities. So that's really all I have, Mr. Chairman, if there's any questions.
Questions, Representative Clouston?
Thank you, Mr. Chairman. Yeah, I guess part of me is the free market, let free market go, and if it works out, great. My hesitation, though, is hearing from these surgeons who don't want it. In your facility, if there's a surgeon who says, I don't want the CAA helping, I just want the nurse anesthesiologist or the actual anesthesiologist working, can that surgeon pick, or do you see a place where they don't get a pick and they have to put their patient through something they don't want to?
Mr. Hannes?
Mr. Chairman, Representative Clouston, like I said, that's determined through medical staff bylaws and the way that they align their resources and who's in the room. Certainly surgeons are a part of that policy making inside the facility. I couldn't speak to exactly how it would operate in each facility, but generally a facility would make arrangements in that way.
Okay, further questions for hospitals? Representative Hornock.
Thank you, Mr. Chairman. So if the hospital needs to work on their bylaws, work on their policies to allow this function to happen, can you do that now without a licensure? This particular AA, could you work on those bylaws and things and change things so that you can allow this without going through this licensure policy?
Hannes.
Mr. Chairman, Representative Hornock, I think if I'm understanding so I guess I would sort of refer you back to what Mr. Bonham-Bless just said about non-licensed professionals being delegated responsibilities in an operating room. I mean, maybe the scenario you pointed out is possible, but I don't know that that would take place.
Further questions? Seeing none. Thanks, Josh. Ms. Declever?
Why are you letting them go?
Thoughts from the Nurses Association.
Thank you, Mr. Chairman, members of the committee. Tony Declever with Wyoming Nurses Association. The CRNAs, just as you've heard previously, have been in opposition to this bill, and they have their own kind of organization, but the Wyoming Nurses Association also has members that are CRNAs, so we support them. But in our state, as many of the western states, the the level of a certified nurse anesthetist is considered an advanced practice nurse. And in Wyoming, advanced practice nurses have full practice authority, which means they do not need to be supervised. Now there is for the CRNAs, there is a provision through CMS that the governor of the state can state, even to states with full practice authority, we want you to have supervision in an operating room. And in the past, that supervision has been the surgeon. It's not been an anesthesiologist. It's the surgeon is the supervising doctor. We have been working with the governor and the Department of Health, and so that the governor has decided or made the decision to do what's called an opt-out, which means that now it's in the rulemaking process right now. So CRNAs do not have to be supervised at all by the surgeon or by another anesthesiologist. So they can practice independently of oversight. Now, the rules as they're coming out states that for the first 3 years of a CRNA's practice, so once they graduate from school, those first 3 years, they have to be supervised, but after that, they can practice independently. It just is a little bit of information about how that works in our state, because it doesn't work that way in all states.
Okay, questions from the nurses? Representative Hornock.
Thank you, Mr. Chairman. The way that this operates now, would you say that it does reduce healthcare costs overall, the way that we're operating here in Wyoming? And if we enacted this legislation, do you foresee that healthcare cost then for surgeries rising? Thank you.
Mr. Chairman, Representative Hornock, I actually am going to defer that question to our CRNA representative that's here. But traditionally, nurses are always paid less than physicians. So if an anesthesiologist is performing, is at the head of the table, and in this hospital, and a CRNA is at this one, the CRNA is going to receive less. That's just, it's always kind of been that way, unfortunately.
Further questions?
Could be the fact they went to medical school.
Thank you.
Before we call up the CRNAs, are there any doctors or anesthesiologists in the room who'd like to testify? Seeing none currently. With that, CRNAs, come up. Is there one online? There is a doctor online. We'll pull him in, and if you guys want to come up as well, you're welcome to. We'll pull in Dr. I'm going to go with Fortier. And we're going to ask him. Hi, doctor. We're going to give you the floor for about up to 4 minutes, if you're with us here.
You're muted, doctor.
There he is. There you go. Welcome. If you would state your name, floor is yours.
I'm Dr. George Fortier, from Torrington, Wyoming. I've been practicing in rural medicine as a surgeon for getting close to 35 years now. I've looked over this bill. There's a great deal of misunderstanding, I believe. Over the years, what I have seen is that less and less qualified individuals are being put into positions in an effort to save money. The problem here is that I think the scope of the scope of the practice that is in this bill, which was skipped over briefly, is giving these AA candidates the ability to practice essentially independently, that they're being overseen by an anesthesiologist in up to 4 rooms. The whole idea of that is, I don't think, is good medicine in the first place. The the ability for one physician to oversee 4 rooms and meet the Medicare guidelines that they was responded to earlier as the TEFRA is really impossible except in a 1-to-1 situation, in which case it would not make any of this financially viable or would save any money whatsoever. The bill wants to give these AA individuals the ability to not only administer anesthesia, to do the induction, and to manage the drugs throughout under supervision, which in up to 4 rooms. Well, the abstract that I've read from the American Association of Anesthesiologists said that even in a 1-to-2 ratio of anesthesiologists to a not necessarily an AA, but even a CRNA, the TEFRA rules are not fulfilled 35% of the time. And you can take that all the way down to the 1-to-4 ratio that was promulgated earlier. And at that point, the TEFRA rules are not fulfilled 100% of the time. I would not have an AA doing anesthesia without an anesthesiologist in the room with them all the time. I don't think it's safe for patients. Anesthesia is a potentially dangerous portion of the operation. And I don't think these people are qualified to function as an anesthesiologist or as a CRNA.
Right, just because we're a little bit of a time crunch, any questions for Dr. Fortier? Not seeing any. Thank you very much for being here today, Doctor. Certainly appreciate your time.
Thank you.
Thank you. With that, CRNAs, welcome. Welcome, Ms. Johnson.
Thank you, Mr. Chairman, members of the committee. I'm Erin Johnson and here before you today with the Wyoming Association of Nurse Anesthetists. And I will turn over my time to Tracy Richard, who is a board member for that association. Thank you.
Thank you. Hi, Ms. Richard. Welcome.
Mr. Chairman, committee members, my name is Tracy Richard. I'm a certified registered nurse anesthetist. I've been an RN for over 21 years and a CRNA for over 10. I practice in hospitals and healthcare facilities throughout the state, and I've also practiced in Colorado, Nebraska, and Pennsylvania. To tag on to what Dr. Fortier was talking about as far as the TEFRA rules, I just wanted to touch base on that. It was made, the comment was made about that there was a change to the rules, that they did not have to be there for induction as an emergence as appropriate. What that's a reference to is when providers are providing a different type of anesthetic, what's called monitored anesthesia care, where the patient is sedated for the procedure, but not intubated and under a general anesthetic. They aren't induced into a general anesthetic. Or say they have a spinal for a total hip surgery and they're being sedated as well. It's not an induction. The patient can be stimulated and woken up. So that's what that means. It still means anytime there's a general anesthetic that needs to take place and that patient has to be induced and an ET tube placed and we take care of the patient, they have to be present for that. That does not keep the physician anesthesiologist away from that responsibility of having to meet that responsibility for following the TEFRA guidelines. So I just wanted to preface that. And let's see, also in reference to, there was a reference earlier to not getting to hear from many surgeons and their opinions on it. So I'm super glad that Dr. Fortier spoke, but I have 2 letters here. You all should have received them in your emails the other day. One is from a well-known orthopedic surgeon in Colorado, Dr. Kinswater, from the Orthopedic and Spine Center of the Rockies. And I'll just read a little excerpt. As a surgeon who has performed more than 25,000 hip and knee replacement surgeries, the time it would take to stagger surgical case starts to accommodate the medical direction requirements for AAs would distract from our efficiency and ultimately the quality of patient care. Time in the operating room garners a cost to the facility and to the patient. In an institution that values efficacy, quality, cost effectiveness, and AAs are a non-factor. The future of healthcare in the United States is dependent on the rigorous pursuit of efficiency and cost reduction while maintaining high rigor for quality and safety. I recommend against the licensing of AAs in Nebraska. This was written for Nebraska. They just did get AAs accepted for licensing in Nebraska, but he wrote this for against the Nebraska bill. The risk of driving out cost-effective and proven guardians of safety in CRNAs is too great, and the ability to utilize AAs too little. Also, in regards for a Nebraska, a letter that was written in regards to the Nebraska situation. This was a letter, you all should have got this as well, of 167 physicians, surgeons, and anesthesiologists as well, who signed this bill against AAs. AAs are not a desirable option for patients or for our Nebraska healthcare system. AAs must work under direct supervision. That supervision may only come from a physician anesthesiologist. Therefore, AAs cannot work anywhere where there is no physician anesthesiologist. In a predominantly rural state like Nebraska, it makes AAs a non-factor for relieving patient access to care issues or for controlling healthcare costs. Furthermore, there are no peer-reviewed studies of scientific journals that have been published in regard of the quality of care or outcomes of involving AAs. The quality of care of AAs is unproven. If an AA supervising anesthesiologist is not available for any reason, working off-site, day off, etc., the AA cannot provide anesthesia care. If emergencies occur simultaneously in different operating rooms, lapses in supervision would likely occur and anesthesia care would be impacted. There is nothing to demonstrate this would be safe or in the best interests of our patients. So there's hearing some from physicians, granted not from Wyoming, but a neighboring state that's in the similar situation we are, which is mainly rural. We have three main issues with this bill. AA training and education is not the same as CRNAs. Lack of studies of AAs proving safety in anesthesia care, which was already hit on this one. Risk of fraudulent billing of Medicare and other insurances. Requirements and standards for admittance, graduation, and licensure of AAs and CRNA programs are as follows. AAs are required to have a baccalaureate degree of any type. That could be accounting, political science, whatever, before they can get accepted into a program. CRNAs require a baccalaureate of nursing degree. AAs recommend general pre-med classes. They are required at some, but not at all. AA programs, there is no requirement for any medical or healthcare experience prior to entering the AA program. CRNAs require RN licensure and practicing of a minimum of 1 to 2 years in a critical or intensive care unit. There we learn and master the following things of interpreting EKGs, demonstrating and titrating medications, providing CPR and advanced life care support. We also do monitoring and interpreting of advanced cardiac output. We manage ventilators, we run infusion pumps and all other sorts of medical machinery and know how to use it before we start our anesthesia training. Requirements for graduation for AAs are a 24 to 27 month program, which confers a master's degree. CRNA programs are 28 to 48 months, conferring a minimum master's degree, with most being doctoral. By 2025, all will be doctoral and all will be at least 36 months. AAs are recommended, they are not required, to do 600 surgery cases and 2,000 clinical hours. AAs count every hour they are in the hospital and simulation lab as clinical hours. This includes learning to conduct physicals, take patient histories, attend ACL classes, and learning and assessment skills. RNs or CRNAs require a minimum of 650 surgery cases and 2,000 clinical hours. CRNAs are not allowed to count clinical hours the way AAs are. It is only counted as actual time performing anesthesia. So if we were to count our time the same way as AAs do, we would have a minimum of over 2,600 hours in CRNA school and over 6,700 hours if counting the minimum of 1 to 2 years experience prior. And most of it is 5 years. Most of us are at least nurses 5 years before we go in. AAs, there is no minimum requirements for didactic or classroom hours. CRNAs, there is a minimum requirement of 450 didactic or classroom hours, with most providing over 600. AAs graduate with a national licensure as dependent practitioners to be physician extenders or assistants who must practice under the direct supervision of an anesthesiologist, no other physician. CRNAs graduate with national licensure as trained to practice, function, and provide anesthesia services completely independently of any other provider, just like a physician anesthesiologist. Wyoming CRNA licensure is independent without supervision. And again, as the Wyoming Nurses Association talked about, the opt-out is an option that we are trying to get through right now with the governor. I'm going to also jump over to the TEFRA rules. I really want to make sure everybody understands this, the risk of fraudulent billing. Medical direction rules.
Ms.
Yes.
Richards, I mean, maybe I don't speak the whole committee, but
Yes.
it's Friday, and there's a lot of numbers and a lot of stuff you're throwing at us there,
Okay.
and we're not the
Fair
most,
enough.
some of us are practitioners, but
Okay, fair enough.
so you don't have to go into a whole bunch of numbers, but maybe.
Can I hit on one more thing? It's
Oh, yeah,
it's
one more
literally
thing,
a
please.
short little deal. In reference to the comment that was made about CRNAs monopolizing the market, CRNAs practice independently, MDAs practice independently. AAs cannot practice independently. We don't monopolize a market. We can practice independently. We can also practice with a physician. We can also practice with an anesthesiologist. So there's no monopolizing going on. Monopolizing happens with the AAs because they are a tool that can only be used by anesthesiologists. So they can run 4 rooms to our 1 room. So if we want to talk about monopolizing, it would be AAs. I
And
apologize.
that's, no, you didn't apologize. That's ultimately the true rub or the true difference. If you had to give me the 30-second, explain it to me like I'm in elementary school, what the opposition is because ultimately AAs working under an anesthesiologist can do basically up to 4 rooms at once, where CRNAs have to do one-on-ones.
Yes, I would say that's the competitive
Competitive
market
dis-
rub.
mhm.
But the number one issue for us is safety and cost effectiveness and efficiency.
Questions, Ms. Richards? Representative Penn?
So I just wanted to clarify a couple of the things on the TEFRA rules, because that's been mentioned several times, and I think that seems like that's the kicker. I mean, the rules there are to make sure that safety, that the patient's safety is at heart. And so the couple things that I noticed, the first 2 requirements that must be met in order to legally bill for these services is that the anesthesiologist perform the pre-anesthetic exam and evaluation. And the second one is that the the anesthesiologist is the one that prescribes the anesthesia plan. But when I'm looking at this bill, it appears as though we've given that scope to the CAAs. I don't know if you have any comment. Do you think I'm correct on that?
Go ahead, Mr.
Mr. Chairman, Representative Penn, yes, thank you for that question. As the bill is written, yes, it allows for complete delegation of that, which would then be above and beyond what's required for TEFRA billing to be able to bill directly for direct supervision, because you're then at the state level negating a federal requirement. They're saying that he could be somewhere else doing something else and go ahead and delegate them to do those processes, or to delegate that patient, the AA, to wake that patient up, that emergence from anesthesia, or put a patient to sleep. Yet that's a requirement that they have to meet, the physician anesthesiologist, to be there to be able to bill. So it doesn't confer.
Okay. Further questions, Ms. Richards? Seeing none, Ms. Johnson, thank you. Anything further? Okay. Any other people in the room wish to testify before I go online? And Chairman Harshman, if you had to give me your best guess on how long your bill is going to take? It's just a little bill. Okay. So, committee, let's do about 12 minutes of testimony, 5 minutes to work the bill, then we'll try to get to Chairman Harshman's at 9:30. With that, anyone else in the room on this bill? Okay. Let's go online. Ms. Lunsford, come on in. And then anyone else who wishes to testify on this bill who is one of the 3 people in the waiting room, please raise your hand. We'll bring in Ms. Kemp. Oh, all of them. All right. First up, Ms. Lunsford, the floor is yours.
Hi, good morning, Mr. Chairman and members of the committee. I'm honored to testify in front of you today in support of House Bill 122. My name is Brandy Lunsford. I'm the president of the Wyoming Academy of AAs, and I've been a practicing CAA for 8 years. As Ryan mentioned before, I grew up in Evanston. I still have strong ties to Wyoming. My parents live in Evanston, where my mom is a teacher and my dad is a detective. I have several siblings at the University of Wyoming and another that's an occupational therapist in Kemmer. I got my undergraduate degree in cell biology and chemistry from Utah State University. While I was studying there, I was on track for either PA or medical school, and I was unsure of which path to take when I heard of the CAA profession from a friend. After shadowing an anesthesiologist who was also excited about the idea of working with CAAs if given the opportunity, I decided that this would be a good fit for me. So I started Emory's AA program shortly after graduating from Utah State because the requirements for Emory's CAA program are similar to that of PA and medical school. I'm happy to go into that in more detail later if you request. My degree included 2 years of rigorous courses and 2,500 clinical hours of intense training. And I do want to make a clarification of what was said earlier. Our lab simulation that we do in our training is not counted toward our clinical hours. Clinical hours are strictly training in the hospitals. So my training, my preceptors included anesthesiologists, residents, CAAs, and CRNAs. I was trained by CRNAs. I trained in all specialties of anesthesia at Emory University's hospitals and other hospitals across the country, including the University of New Mexico and the University of Utah. And I just want to make a note that we are trained to handle emergency situations on our own. We can do that. We do reach out, obviously, to the anesthesiologist who's supervising us if there is an emergency, but we are trained to handle this. So after my training, I graduated with a Master of Medical Science in Anesthesiology from Emory's Medical School. It wasn't my intention to relocate permanently to the South, and I do miss my home state of Wyoming. I've been working in Atlanta, Georgia at Emory St. Joseph's Hospital for 8 years now. I administer anesthesia for patients undergoing surgery and various other outpatient procedures under the direction of an anesthesiologist and alongside my CRNA coworkers, where we work together cohesively. Some of my best friends are CRNAs, and it's actually hard to make the distinction between who is a CAA and who is a CRNA in my hospital because we have the same responsibilities under the anesthesia care team. I wanted to mention the Wyoming Society of Anesthesiologists fully supports allowing CAAs to practice in Wyoming, and they fully support this bill. Enactment of this bill would provide the residents of Wyoming an opportunity to receive the same quality of care that many other states, including Colorado and Utah, are already utilizing. And it would give people like me a chance to work and live and raise our families in a state that we consider home. Thank you.
Thank you. Is
Any
there
questions?
Representative O'Hearn? Go ahead.
Thank you, Mr. Chairman. How many hours would it take of study and clinical work from a CAA to a CRNA?
You mean if they were to transfer over, Representative O'Hearn? Is that okay? Go ahead, Ms. Lunsford.
Mr. Chairman, Representative O'Hearn. So just to clarify, you're asking if I wanted to become a CRNA, how many
Correct.
hours of training would that require?
Yes, please.
Mr. Chairman, Representative, well, in order to do that, I would have to get a degree in nursing and then go and complete you can't transfer. You would be starting over from the beginning.
Thank you.
Further questions? Seeing Representative Yen.
Thank you, Mr. Chairman, Ms. Lunsford. So, thank you for providing testimony. You know, I think it's always saddening when we hear folks from Wyoming who can't come back and work in Wyoming. I'm curious on whether you heard the Hospital Association's testimony and whether you know of a hospital that you would be able to work at that would accept anesthesiologist assistance if this were to pass.
Ms. Lunsford, if you know.
Mr. Chairman, Representative Yin, I don't know of a specific hospital. I do know the Wyoming Society of Anesthesiologists gave us some information that there were areas, surgical centers, et cetera, in Gillette and Cheyenne that were interested in hiring AAs given the opportunity.
Okay, other questions? Seeing none, thank you for being with us today, Ms. Lunsford.
Thank you.
Yep, have a great day. We're going to go to Sundance Kemp. And welcome, and if you could try to keep it to about 2 minutes or less. Floor is yours.
Absolutely. Good morning. Thank you for taking time to listen to me today. My name is Sundance Kemp, and I'm a certified anesthesiologist assistant. I was born and raised in Montana. My family ranch is in Glendive, and I grew up like a lot of young people in the region of the country, playing multiple sports each year while working on my family's ranch. After high school, I decided to serve, and I enlisted in the United States Marine Corps, where I served honorably. I then went to college on my GI Bill, attending the University of Arizona's Undergraduate College of Medicine, where I graduated magna cum laude with a degree in physiology. While in school, I worked in a microvirus lab, where I was later able to publish my undergraduate work in the Journal of Virology. After college, I chose to attend the Indiana University School of Medicine, where I earned my Master's of Medical Science Anesthesiology degree. Anesthesiologist Assistant School is an intense clinical and didactic experience. We average over 2,500 clinical hours. We do not utilize our sim lab hours as our clinical hours. It's all in the operating room. We do the full spectrum of cases from cardiac to neurosurgery to high-risk OB. We rotate in a diverse set of hospitals from large level 1 trauma centers to small rural hospitals. We are taught how to and expected to personally perform central lines, arterial lines, IVs. We also go through APS rotations where we're taught to perform various regional anesthesia blocks. We are taught by a mixture of anesthesiologists, CAAs, as well as CRNAs. I currently work in a level 1 trauma center where I do the full spectrum of cases. I do hearts, neurosurgery, I do traumas. As a CAA, I work in the anesthesia care team model under the medical direction of an anesthesiologist. Our care teams are composed of a mix of dozens of CAAs and CRNAs who are indistinguishable from each other clinically. We work together to provide the highest possible quality of care for our patients. And we perform the same roles. We're completely interchangeable, and we value each other's skill sets, and we often rely on each other in stressful situations. Allowing CAAs to come into the state would open up a pool of thousands of anesthetists to potentially come to Wyoming. This would offer the citizens of Wyoming greater access to quality healthcare. We would immediately be able to fill shortages in the currently existing anesthesia care teams in Gillette. And this would allow their hospital systems the opportunity to hire CAAs if given the chance. We're just asking that you guys allow the market to play out. And if people want to hire us, that we are available for them to hire. I wanted to address a couple of points that were said earlier. The Epstein study was mentioned where they said that a large majority of the cases under medical direction, the billing wasn't met. The requirements for billing weren't met. That study didn't include any CAAs. In addition, we are required to have 600 cases. There was a mention that we were not required to have 600 cases, and all CAA schools are required to have a pre-medical background. Thank you, and are there any questions?
Thank you. Questions, Mr. Kemp? Seeing none, certainly appreciate you being here today. Let's go to Ms. Thatch. Have a great day, and thanks for dressing up. We don't get, yeah. All right, Ms. Thatch, floor is yours.
Okay, good morning. My name is Kennedy. I'm from Lander. I am currently a CAA practicing in Tampa, Florida. My path started at Lander Valley High School. I then went to Michigan State to get an undergraduate degree in neuroscience. From there, I went to Indiana University School of Medicine to get a master's of science in cellular and integrative physiology. I was working there as a tissue recovery technician in transplant and learned of CAAs and their role on the care team, which led me to Nova Southeastern to earn my master's of science in anesthesia. You've heard a lot of things about our profession as we move through this process, stating we are undereducated, underqualified, and unsafe. These are self-serving claims that are not based in fact. All of us have kind of mentioned how our training is virtually the same. Our 70 didactic credits are thorough in helping us understand human physiology, pharmacology, and disease states, and how we can tailor all of our anesthetics to each individual patient. CAAs are licensed and practicing in 19 other states. This is not an experiment. Colorado and recently Utah utilize them now, and a lot of our citizens actually travel to Utah and Wyoming to get specialized care and surgeries. So Wyoming citizens are already being cared for by anesthesiologist assistants. Adding physician extenders improves accessibility and ensures physician-led medicine is preserved. Wyomingites want physician-led medicine. I know the CRNA has talked about the opt-in that just happened with Governor Gordon, and the Wyoming Association of Anesthesiologist Assistants and the American Society of Anesthesiologists put out a survey to the citizens of Wyoming. They found that 75% of Wyoming voters oppose permitting nurse anesthetists to administer anesthesia without the supervision of a physician, and 93% want to be informed if a hospital does not have a physician anesthesiologist. So the anesthesia care team model that CAAs practice under ensures that Wyomingites receive the highest quality and safest medical care that they deserve, despite Wyoming's unique challenges. So supporting this bill will bridge one gap in healthcare for the underserved people of Wyoming. My family and the community that raised me deserve access to physician-led medicine. Licensing AAs extends physician anesthesiologist reach. So thank you for your time and allowing us to speak with you and explain our field and our passion for people of Wyoming.
Thank you, Ms. Fetch. Any questions from Melanderite? Seeing none, appreciate you being here today. One last testimony from Ms. Campo. Welcome, Arlene, floor is yours.
Good morning, Mr. Chairman and committee. Today I'm here representing Powell Valley Healthcare. I'm the Chief Nursing Officer at Powell Valley Healthcare, and my statement is very short. As a Chief Nursing Officer of a critical access hospital, critical access hospitals are very limited in the revenue that they are able to collect. And as such, often critical access hospitals cannot afford to hire anesthesiologists. This would be an increase in cost for our organization if we hired anesthesia assistants, because we would have to hire a medical doctor of anesthesiology. As such, I do not see that there will be a great hue and cry for anesthesiology assistants throughout the state, as most of our healthcare in the state of Wyoming is quite rural. And then that would also, I'm not sure that would justify setting up a board to certify or license the anesthesiology assistants. As well, I do believe that our quality of care would not be as good, not because they aren't trained or that they don't do a wonderful job, but when you have to have oversight by an anesthesiologist, it's very difficult for an anesthesiologist to have oversight of more than one person. And I believe that in and of itself decreases the quality of care for our patients, especially during times of emergency. Thank you very much, committee, and Senator Zwanitzer for having me here today.
Thank you for being here. The roads are not open yet, so it's good that you could testify not in person. Anyone have questions? Powell Valley. Seeing none, thank you. Have a great day.
Thank you.
With that, committee, we're going to close public comment. Is there any motions on House Bill 122?
I move it.
Moved by Representative Ward. Is there a second?
I
Really?
will second.
Okay, second by Representative Yen. Any amendments on the bill committee? It basically is a practice act, and I do believe the language has been gone through previously, but if anybody did have any amendments, certainly entertain them at this time. Not seeing a lot. Any discussion on this bill? I'd just like to say this was much better than the ophthalmologist optometry practice act wars we had. This was much friendlier, and people were very respectful. So for all of you online and in person, certainly appreciate that. Representative Clouston, comments?
Thank you, Mr. Chairman. Yeah, I'm not totally against this bill. There's parts of it I really like. I like the profession. What I need to hear is that the hospitals think that this is a good idea, and I need to hear that the surgeons want this. So I guess until I have those two backing this bill, I'm not comfortable passing it right now.
Other comments, Representative Penn?
You know, for me, it comes down to safety. This is, I think, from what we're gathering here, it's more than just a turf war. It kind of seems to be trying to be presented that nurse anesthetists don't want them because then they're on their turf. But it comes down to safety and looking at the ratios. I mean, anesthesiologists want it because then they have the potential to share in the billing for 4 OR rooms instead of just the 1. But given our rural nature, so many of our facilities don't even have anesthesiologists. So those would be null and void from being able to use this anyway. But these TEFRA rules that they have to live by in order for facilities to legally bill and not be fraudulent, you know, even at a 1 to 2 ratio, it says that only 35% of the time, or 35% of the time, even at a 1 to 2 ratio, then they didn't fulfill all the rules that are required. What happens if an anesthesiologist is overseeing 4 ORs, one goes bad, he's over here, and another goes bad? You know, we still have, and that happens. I mean, bad days in the OR in the hospitals happen. And why hopefully that doesn't happen very often. It's still something that we have to think about safety-wise. As was mentioned, if the surgeons aren't on board, that raises big questions to me. And I just don't think that, given our rural nature and the few numbers that this would be servicing, that's, you know, in our best interest at this time.
All right, any other comments for the vote? Representative Ward?
Yes, I moved the bill because, and I understand those things, and honestly, I'm a little torn here on this bill. My reasoning is that it seems to increase freedom and the ability to hire these folks who are trained. But the hospitals don't have to hire them, then they can create policies that they're not going to hire them. This only makes the option available, and for that reason, that's why I moved the bill.
All right, Representative Trujillo.
I'm just looking at the titles, and I used to be a CNA, and I used to think, you know, working in the nursing homes, doing everything from 4 in the morning to 10 at night, that, you know, the nurse on call or nurse on site, actually, I was like, she's just sitting behind the desk doing the paperwork. I'm doing all the work. I know I can do this. I know I can do that. However, titles, education, degrees mean a lot. And considering that this is an assistant, it's an assistant position. So that's probably why I won't go for this bill.
Okay. With that, Marilyn, if you'd call the roll on House Bill 122.
Representative Chadwick?
No.
Representative Klauston?
No.
Representative Hornock?
No.
Representative O'Hearn?
No.
Representative Penn?
No.
Representative Trujillo?
No.
Representative Ward?
Yes, aye.
Representative Yin?
Aye.
Chairman Zwanitzer?
Aye. Unfortunately, Representative Berger, 3-6 this year. But certainly appreciate you coming and everyone online testifying. It is always nice when we see young people who want to come back to Wyoming. I just some days wonder if we have the scale and capacity, you know, if we even had this, how many of our hospitals would have capacity for it. So certainly appreciate your time. Have a great morning. With that, committee, we're going to move on to our third bill. Thank you, Chairman Harshman, for patiently waiting today. Next up is medical care for Wyoming communities, House Bill 179. Please welcome Representative Chairman Harshman from Revenue to today's Labor Health Committee. I'm slightly waiting, Chairman Harshman, for the room to clear out behind you, so maybe we'll give it about 10 more seconds. Apparently it is. All right, Chairman Harshman, floor is yours.
Thank you, Mr. Chairman, and members of the committee. Thank you, Mr. Chairman, for hearing this bill, House Bill 179. There's really about 5 things trying to do. First of all, it states in there that our focus is going to be, our emphasis is going to be on rural health care. I think it examines also, without saying it, but is 20 the right number of physicians in WWAMI? And the trustees have the ability to kind of do that with existing language. The other deal is I sent you an email last night, members, and that report, in the history of that report, medical education, it's really a nice report. And I just, we moved to 30 at one point. In the 50s, we were like 12 positions. Through the 70s, we realized we needed more. We went to 20. When I was a kid, it was Creighton, right? That's where all our doctors seemed to come from. And then we had 10 at Utah. And then that lasted for several years. You read the report, how well it was. Many of those folks have been doctors of the day and have been real leaders in Wyoming. And then we've switched to WWAMI, and WWAMI is like one of the #1 primary care ranked hospitals in the country. And when I started, I think we had 12, 14 slots. We purchased a couple more slots as we had Western gas boom and then coal bed methane, and we had more money. And so we're up to 20 slots. So it has that in there as 20 the right number. And then you'll read in that report where it says, well, we only have about 25, 30 qualified applicants. And so I gently put in there there's an idea like at Montana State, which has 30 WWAMI slots, has a program where, hey, you're the #1 civil engineering student. Would you like to take this 1 year kind of pre-med? And you ever thought about being a doctor? And so they go out and recruit the best students in other colleges at the university and bring them in. Hey, you're the #1 science teacher. You had a 34 on the ACT. You ever thought about being a doctor? And so they'll bring them in to increase that pool. And so it puts that little idea in a sentence, and I'll point that out. I think the other part, and I hear my healthcare provider is University of Wyoming Family Practice Residency in Casper. Been going there for 3 years. My wife as well. And know those folks really well. Not that they've specifically told me this, but I hear this. I mean, when a physician is finishing up and they've got offers, I mean, there's some real money involved. And I think if we can do some of that earlier to really maybe pay and maybe help with these residency placements in Wyoming, perhaps we can get, and I tell you, Central Wyoming has really done a nice job with the rural outreach, sending residents to Thermopolis and around and through rural areas. And so it's really been some great work. And so just thinking about, I call it like the name, image, likeness that you hear in college athletics when they're younger, kind of give them maybe a little boost in pay to get make these residencies really attractive. And then finally, Mr. Chairman, it allows, and it's in, I think, paragraph B in this section, but it allows the university, if they need to alter that 3-year repayment and work requirement for certain professions in certain areas, to give them some flexibility. Hey, we need doctors in Lusk. And if you want to go and do, we don't have a physician shortage in Teton County. Not at all. I mean, in Lander, there's not. As I look at this, Teton County has more healthcare providers per capita than the state of Massachusetts, last time I looked, because people want to live in beautiful places and do all that. But some of our rural areas, it's tough. And so, and then finally, Mr. Chairman, this part 2 of the bill really is a reporting piece to you to put this committee really in the driver's seat. And I'll just tell you, Mr. Chairman, I had 4 bills. One was to establish the University of Wyoming School of Medicine. Well, that was going to go down, right? I was just going to throw that out there. And the other one was really this endowment concept that passed the House with over 40 votes 2 years ago. Wasn't heard in the Senate. Budget cuts. One of the first things we cut was our WIN program. I mean, we only train pharmacists and nurses in this state. And everybody else is in the WICHE program or the WWAMI or outside and other. And so I had a little endowment bill. Then I had a little select committee bill, and I thought, that's not going to go. And so I just kind of combined all these into a little gentler thing where I think basically the gist is to put stuff in there that and not tell the trustees you shall very often. And so I think it's language that everybody can live with on that. So, Mr. Chairman, I just walk you through the bill quickly. In Title 21, of course, is education and Chapter 17 is the University of Wyoming. And this is one of the first sections in the law, and this goes back to the 50s really, is about medical education. It says specifically doctors, optometrists, and a couple other professions, but not limited to that. And then the next section is veterinarians. And then it goes on to nurse practitioners has been added and some other things. But so, Mr. Chairman and members, if you flip over to page 2, and you can see this existing, sometimes when you have a bill, you don't have existing language in the bill. So I always try to go read the whole section and get the gist of it. But this paragraph B is amended, and you can see the new language, Mr. Chairman. This is really kind of the first part of the bill where we emphasize rural health care. And so then the board, of course, is the Board of Trustees. And by healthcare needs by geographic area and particular healthcare priorities identified by the Office of Rural Healthcare, and that's under the Department of Health at 92117. If you read that, they've got goals, and those are always updated. And then, Mr. Chairman, the second part is really gently states, I think, on that line 17 and 18 about is the 20 number right? And you read that report, they asked that question, the university, from a couple of years ago. And they can do that already, but want them to come back to you with that discussion, okay? And then it gently says on 19 through 22 about those recruitment programs. If we're only getting 25 qualified applicants, how do we change that? And so that's at 19, and that's borrowing from really kind of a Montana idea. Mr. Chairman, and then flipping over it talks really, this is about these agreements that the board, it gives the Board of Trustees a little more flexibility with their agreements and work requirements and payback on page 3 to adjust that. So it just gives them a little more flexibility. I had a bill that totally adjusted the repayment and the length of service, and it was a shall bill and said, these are the years and this is the amount. And I backed off on that. So I canceled that draft. And And then, Mr. Chairman, on page 4 and members on line 7, that is that, what I call that NIL money early when a medical student is not finished and where they're looking at residency. And I hear this across the state, man, if we could just pay our residencies, make them a little more attractive. So that's what 7 and 8, it doesn't tell them they have to, but gives them that push to kind of look at that. And then finally, Mr. Chairman, on page 5 is that lines 8, where you can see the new language, can adjust the repayment and terms, because right now it's in another paragraph, I think paragraph B or A is the 3-year repayment, that they can adjust that particularly as aligned to rural health care. And then, Mr. Chairman, over on page 6, section 2, the report section starts. I think a lot of this will be, and I guess, there's a lot of history to this, and you think when, it was into the late 1940s, we're still trying to move the capital to Casper. And you think, most Western states, the capital of the state is more geographic. There was a move to put it in Lander, the university in Lander. There was a big move in the 70s to build a University of Wyoming School of Medicine in Casper. That's how we got the 2 residency programs. And I sent you that link if you saw that 1978 bill. And that was just after we changed our constitution, not to digress, but into the wholly undemocratic 2/3 to introduce a bill. But you saw that bill had a majority of House members, but it didn't have 2/3 to get introduced. And you new members will find that out next year when your bills don't get 2/3, and you're going to go, boy, this is really a great idea. But that was done in the 70s in a different time when, amendments were handwritten and everybody smoked in the chamber and had a spittoon. I mean, it's a different era. But going back to this, I often think, would Wyoming be a different place if that bill would have succeeded? If we had a school of medicine in Casper, would Casper be 200,000 people, or would it be, I don't know, would it change anything? I don't know. And we are what we are now. We've got our institutions along the old UP line. And, but anyway, not to digress into the history of that. And I don't want to open that all up, Mr. Chairman. So sorry for the, but the reporting part is really to come to you guys and say, what's this going to look like in 2070? I mean, we're closer to 2070 than 1970. And what is the plan? You know, South Dakota and North Dakota train their own docs and physician assistants and PAs and I'm not saying we're ready for that now, but what is the plan? And so for you guys to kind of hash on that and think about that. And then the reporting part on the numbers, this will be a lot of a update of that report that I sent you last night, the dollars on page 7 on that paragraph A, and then the numbers that are needed in paragraph B, and further legislative action. They said, hey, we need this to help make this. They should come to you with ideas. And then finally, Mr. Chairman, flipping over page 8, paragraph D on line 7. This is an idea in Minnesota. I read about their rural healthcare centers, how they've partnered with hospitals. And we do some of that, but I think it can be improved from what I hear. So it's a suggestion to report back on that. And then finally, E is funding sources. And this bill had $100 million endowment, and I pulled that out of the bill, really to pay for our WIN program and some of our WICHE stuff, because we've cut all that. We've cut WWAMI, WICHE, WIN for our nurse practitioners. And but I backed off of that too. I thought they'd come back and report to you and start thinking big and what are the big ideas and where is this gonna go? And then, so Mr. Chairman, really that's a bill.
Cool. Questions for the sponsor? Representative Penn.
Okay, let me find it here. So on page 2, lines, starting at lines 12, it talks about before entering into contract under the section, the board shall consider assessments of healthcare needs by geographic area. Is there a plan on how that is to occur?
Go ahead. Chairman Harshman, I think it's the next line.
Mr. Chairman, and that is kind of this idea of asking, is 20 the right number? See, because there's talk of, should we join with CU also? Or Utah again? But before doing that, let's talk about, do we need more doctors in Jackson? Probably not. I mean, and so to kind of have that discussion. Now, they can already do this without this bill, but it kind of has them reporting to you, this committee as well, and talking about these issues. So that's what that is really about. So because there's talk about that, I think, and I think I can say that publicly. That's not a thing to talk about. And I love WWAMI, don't get me wrong. I've had my little battles and throwing some darts at times, but it's been overall an amazing experience. And we educate the first 2 years at Laramie. They don't go to Seattle anymore. That was how it started, but we have 2 years of the doctoral program is at the university. Anyway, it's a long answer to a short question, but.
Further questions for the chairman? Yep, another one, Representative Penn.
Yes, please. And then, so on line 19, same page, the board may institute recruitment programs. Do we have any estimation of cost on or how that one would look?
Representative Harshman.
Mr. Chairman, I don't, and I think, Mr. Chairman, that would be to come back to this committee. And really, and as you read that report that I sent last night, it says, you know, gosh, we can't go to 30 because we only have 25 to 30 qualified applicants. And then I hear about this program and investigate what other places are doing. They're going out and recruiting. So that's what it is, just maybe consider something like that. Don't have any idea on the cost, but they'd come back to you with that.
Okay, further questions? Representative Hornock.
Thank you, Mr. Chairman. So from what I understand, we are already doing this program, right? We're already, this is already an existing program that's going on.
Chairman Harshman, if you want to quickly.
Oh, yeah, the WWAMI program,
discuss.
we've been training doctors since the 50s with these agreements with other states. WICHE, Creighton in Utah, now WWAMI, which is Washington, Wyoming, Alaska, Montana, and Idaho.
Okay, so.
Go ahead.
Thank you, Mr. Chairman. Just to follow up, I understand are what we do, is what we're doing here going to solve the need that we have in our rural settings? So we've got an existing program, we're trying to recruit for rural settings. We've got somebody who is recruited, ends up in Farson, Wyoming from the big city, and they go, what in the world am I doing here? Or, you know, I don't know. Are we gonna solve the rural healthcare issue by doing this bill when we already have that system in place and we still have those needs?
Chairman Harshman, if you want to.
Mr. Chairman, this bill is not a solution. This bill is to set up this committee really, to really start working on this. And I think, and it also directs the Board of Trustees with that little bit of language on page 2 to really, and it gives them flexibility to recruit, offer incentives to get folks to go to Farson. And you know what I sent you last night too, I mean, it shows out, they know the problem. I mean, we know the problem. We gotta get Wyoming kids from Shoshone to go back to Shoshone and raise their kids with their grandparents there. And, but this puts a little bolder marker on that to say, consider this rural healthcare needs of Wyoming. And that references that, you know, the Office of Rural Healthcare and their goals in Wyoming.
Okay, further questions? Chairman Harshman.
The work is never done, Mr. Chairman.
Okay, Representative Ward.
It's just a quick comment / question. So you said you sent something last night. I have nothing from you. So are you sure that I had my email address correct?
Go ahead, Chairman Harshman. I don't remember getting.
It was House Labor Committee. So I hope you didn't get it. Okay, I just typed in House Labor and it came up. And
Yeah, I didn't get it from you.
see, that's what I did with the revenue too. Maybe I've got like the 63rd or 4th house. Okay, I'll resend that.
Well, if
sorry.
you would find that, resend
Oh, I
it.
tell you, it's a link to the 1978 bill, Mr. Chairman, and it's a Miss Barron editorial a few years back, and then this study that university. Oh, so I'll figure that out, and I'll ask our tech folks as well. Those are updated. My apologies.
All right, Representative Penn, the question?
Thank you, Chairman. So if you could just help me understand this paragraph on page 4 at the top, you're talking about the fund. Representative O'Hearn is telling me we're talking about the WWAMI fund. And then it goes to add the line on line 6, page 4. Contracts providing guaranteed minimum income during professional residency periods. How much is that going to cost? Or, you know, how much more are we going to be pulling from this WWAMI fund in order to cover that? Because that's pretty broad.
Chairman Representative Harshman, if you know.
Yeah, Mr. Chairman, I think that's totally up to the discretion of the trustees and the president, as we've given them that flexibility to manage that. So, and I think this would be a good thing, and this is the medical school student fund. And it's a fund that doesn't come back to the legislature, and it'd be good for you to learn how much money is in there and what's it being spent for, and what does it look like, and is there ways to, I think this committee would be the perfect group to do it. That's why I have you as the home committee of this.
And there are some parameters on how much can come out if you further read the statute. Some of that's lower on page 4 as well, that there are some sideboards.
There are.
Further questions? All right, with that, University of Wyoming, if you just give me a thumbs up, you like the bill. Chairman Harshman's already got 5 people in the committee as co-sponsors and done his due diligence. Any other public comment from the room on this bill? And no one online as of 30 seconds ago. Let me check once more. No one online. All right, with that, we'll close public comment. Committee, what's your pleasure on 179?
Move the bill.
Moved by Representative Chadwick. Seconded by Representative Klauston. Any discussion or amendments on the bill, committee? Representative Ward, go ahead.
Just wanted to comment why I'm voting no. This is an area I believe should be covered by the free market.
Other questions, comments? Seeing none, it's been moved. Seeing none, go ahead, Marilyn, if you call the roll on House Bill 179.
Representative Chadwick.
Aye.
Representative Klauston.
Aye.
Representative Hornock,
No.
Representative O'Hearn,
Aye.
Representative Penn,
No.
Representative Trujillo,
Aye.
Representative Ward,
No.
Representative Yin,
Aye.
Chairman Zwanitzer.
Aye. Thank you, Representative Harshman. You'll have it on the floor. With that, committee, congrats on making it through 3 bills and still having 8 minutes to spare to get to the floor in time, because I know the speaker yesterday was not happy about people being late. So hope you all get to the floor by 10 a.m. start time, and there's an amazing bill that went 9-0 in this committee on violence against healthcare workers up first on committee of the whole. Any help would be appreciated.